Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto, and I am joined by some of my chief residents. I'll let them introduce themselves.
I'm Dr. Eric Acker. I've been on a few of these episodes already.
I'm Dr. Michael Bass. I'm one of the PGY3s. Thanks for having me.
Absolutely. This is an exciting episode. So what are we going to talk about?
We're going to tie all these little topics together that we've been talking about, and we're going to get to what most people and residents want to know. How do I get this patient from intubated onto a vent, and how do I turn those dials on the vent for that patient to get them breathing right?
Yeah, how to set up the vent, right? So we got some cases, which I think will be super helpful, and we'll tackle it that way. Just go through a few different cases.
Sounds good.
A little framework before we hit the cases. So we're going to go over the standard setup. Everyone asks, what dials do I have to turn? We'll go through a case like that. We're going to go to a case of metabolic acidosis, a case of obstructive lung disease, and then the one that can get pretty complex is refractory hypoxemia. Let's reserve that one for a different talk. Let's go through these cases. We'll walk through them, what vent mode to choose and the dials you can choose, etc. As a little bit of non-evidence-based medicine to hear. So a bit of preference, but let's go through these cases. Mike, you have a case for us?
Yeah, I got one just ready for you. We have a 32-year-old male found unresponsive after a polysubstance overdose. Looks to be alcohol and benzodiazepines. GCS of 6, protecting their airway has been a concern in the ED. There's no significant prior lung pathology, ABG showing a normal pH, PCO2, and oxygenation pre-intubation.
Okay, so that's pretty straightforward. We just need to set up the ventilator. You can choose any mode you want. If you want to choose AC volume, AC pressure, I wouldn't choose pressure support right off the bat because maybe you've paralyzed this patient and they're not going to trigger, or PRVC. So you have any mode at your disposal. That's the first thing. Choose your mode. We talked about in previous episodes. If you only know one mode, you'll be okay. Modes are there for patient comfort. Choose any mode you like.
Let's say, for instance, let's do the volume assist control.
Okay, volume assist control. Let's start with that one. Here, basically, you have no significant CO2 elevation. You're not worried about any lung pathology. They're oxygenating well. So we're going to choose volume control, AC volume control. So you get two types of breaths there. If they trigger it, they'll get assist. If they don't trigger it and they're either sedated or still paralyzed, they're all going to get controlled breaths. So here we're going to set the tidal volume. And again, we talked about last episode, setting that tidal volume somewhere in the lines of 6 mLs per kilo, plus or minus 2 if you're kind of an ARDS land, 6 to 8 for most patients on a ventilator. So I would figure out their ideal body weight, calculate it, set it somewhere about 6 to 8 mLs per kilo. That'll be your tidal volume. So every time they trigger a breath or it's given to them, they'll get a set tidal volume of about 6 to 8 mLs per kilo. And then we got to set a rate. So here we don't have a significant elevated CO2. We're not worried about them blowing off CO2. So you choose a standard rate. Somewhere between 14 to 16 breaths per minute would be a nice start to keep our patient ventilating well, blowing off CO2. You're going to choose a PEEP on these patients, and they have no significant lung pathology. So a standard PEEP is about 5 centimeters of water pressure, because now we've violated their glottic opening and we have to maintain that PEEP for them to continue to maintain gas exchange. And those are the main things. We got FiO2 and PEEP. That's going to get your oxygenation. A lot of therapists will start with 100% FiO2. That's fine. We want to make sure they didn't develop any hypoxemia during the intubation. We could put them on 100%, but I quickly go down as far down as I can to get them at something less than 50%. I do that quicker than others. And then I see what they need. I work the other way, where sometimes I'll see, whether it's in the ED or ICU, the therapists get quite busy and they're 100%. If you don't go back to turn that dial down, they can get stuck at 100%. And we don't want to give them 100% FiO2 if they don't need it, because that can also cause injury. So I would keep the 100% for a couple minutes, drop it down, and then go up to what we need to maintain oxygen saturations somewhere between 92, 96. You don't need your patient always at 100%. So figure out what they need, maintain that between 92, 96, and that's where your FiO2 should be.
So you're not just leaving them on FiO2 of 100% and walking away?
I'm going to clearly communicate with my therapist, and by the time we intubated, have them 100%, I see their sats are nice at 100, can't go any higher, then I will drop it down to maybe 30, 40%, see what they need. If they don't desaturate there, I'll let it go. But if they do some desats, then I'll go back up and find out exactly what they need.
And just for reference, you're talking about that you're wanting to check and see the ventilator settings. How far out after you intubate the patient are you wanting to get like an ABG? And do you need an ABG versus VBG? and
Great
severe.
question. Great question. I'm pretty confident with my oxygenation being my saturation on my vital signs. So I don't necessarily get an ABG to see my oxygenation because I can see the SAT. If there's a question, they're poorly perfused, and I don't think that SAT's honestly correct, then I might get a blood gas to see what their PaO2 is or their SaO2 is. I might get one blood gas here after 20 minutes or so, just to make sure their CO2 level is okay. And I'm not making big changes in their minute ventilation, then I don't need frequent blood gases. I think a VBG is adequate to see what their CO2 level, pretty good estimate of where we're at. So I'm okay with a VBG and not sticking my patient unless they have some reason, an arterial line, then I'll sample that. But a VBG is fine for me.
Perfect. So moving to our next case here. This patient is coming from the ED. He thinks that this patient's in DKA. They're very acidotic, pH of 6.94. The bicarb is about 4. PCO2 20. This patient's apparently in the ED, they're being reported to having mental status changes. They're becoming more lethargic and intubated for airway protection.
Wow, the intubated DKA, this is something you want to avoid, okay? But it's obviously something that if you have to do because they're no longer blowing off CO2 and they're becoming lethargic, then you have to take over that airway. And you have a big responsibility here because it's hard on a ventilator to blow off the CO2. DKA patients or anybody with severe metabolic acidosis can do it much better than a ventilator can. So that's the category we're in here. Severe metabolic acidosis. Here it's DKA. And I'll just make one note about this. A lot of times when I talk to my respiratory therapy colleague, they'll get a little confused about what I do with the ventilator because they'll say something along the lines of, why are we doing these adjustments on the ventilator by blowing off CO2? This is a metabolic issue, not a respiratory issue. And I say, you're right. You're very astute. You identified it's a metabolic acidosis, but now we've taken over the patient's airway and we are responsible to blow off that CO2 because we can no longer allow them to do it because they're intubated and sedated. So I do tell them we're working on correcting the metabolic acidosis, but in the interim, we have to blow off that CO2 to maintain a somewhat normal pH. Eric, I've had this case, unfortunately, too many times. I've seen it on pediatrics and I've seen it on adult. And the concern here, and I've seen cases where we've had like miracles happen on a ventilator. I've had a case I remember years ago where a patient got intubated for DKA, extremely low pH, and then got paralyzed initially at intubate and en route. And the ventilator was not set up with a high rate. And this patient nearly coded on us. Thankfully, we were able to adjust it. So let's talk about how we are going to adjust the ventilator. Here's what I like to do. And again, this is my preference. I put them on assist control volume here. I know we just talked about assist control volume, but I like assist control volume because I'm really trying to target minute ventilation. I could put some things in the show notes about what a normal minute ventilation is to keep a PCO2 of 40, what an estimate would be to get it lower than that. But I want to get a pretty adequate tidal volume. We talked about ideal tidal volumes being 6 to 8, 6 plus or minus 2. Here, I'm going to go on the higher side. I'm going to go 8 mLs per kilo with a sort of a volume mode. I can use PRVC here too. So that's pressure regulated, volume controlled. So I'm targeting a higher tidal volume along 8 mLs per kilo. So my mode can be PRVC, AC volume control, higher tidal volumes here, going on the higher end, 8 mLs per kilo. Now, instead of a normal rate, I have to do for the patient what they cannot do for themselves because they're sedated or even paralyzed. I got to crank that respiratory rate up. And my eyes are going to the flow pattern, which is a volume over time. That middle column on the ventilator is your flow rate. So I want to make sure I put that rate as high as I can possibly get it, depending on your pH level, to maintain a normal pH. In this case, you said less than 6.9 or 6.94. They probably need a rate somewhere in the high 20s, maybe even the 30s. But I want to prevent air trapping, which we'll talk about a lot in the next case. So I'm giving them that volume in, the inspiratory flow you got to look at, and you want to make sure the expiratory flow gets back to zero, meaning what came in has come out, optimize the rate, and blow off that CO2. The other thing here, FiO2, PEEP, again, pretty standard stuff. We don't think this patient has a significant lung disease. So I'm choosing a PEEP of 5 unless there's some lung disease, an FiO2 starting high, then going down, make sure they're in adequate range to sat between 92 and 96. But the key concept in this patient is two things. One is communicating your respiratory therapist who may come in the room. They may not know what the underlying disease process is in your patient. Here, severe DKA, metabolic acidosis. So you have to tell them, I need a very high rate. Optimize your rate. And then we're going to get a blood gas in a good 20 minutes. Just give the time for the ventilator to work and make sure your pH is improving. Ventilator doesn't magically correct metabolic acidosis. In this case, the insulin infusion will, and all the other therapies you're giving them. But again, you're trying to do what the patient can do. So severe metabolic acidosis, bottom line is choose some kind of PRVC mode, AC volume, target a high tidal volume, 8 mLs per kilo, and a high rate, and you don't want air trapping. So target a higher rate and then watch that pH. And then as they're improving, lower that rate. Or as they're waking up, put them on a supported ventilator mode, like pressure support. Let them do it themselves once they can, because that's always better than what you can do.
If you are having a little bit of air trap in this auto PEEP situation, what are you changing on your set?
Do we have a case that you guys want to bring up about somewhat obstructive lung disease?
So I got one more case for you if you're ready.
What a coincidence.
All righty. So let's say you're working in the ICU and you got called by the ED and you have a 27-year-old female, known asthma, presenting in status asthmaticus. You notice that she has severe wheezing on exam, severe extensive accessory muscle use. ED thankfully already got an ABG that shows a pH of 7.12 and a PCO2 of 78, and you are called to intubate this patient. What do you do?
Well, I'm hoping we tried everything first. We try to avoid intubating the asthmatic or the COPD, especially in COPD, mortality could go up. So we try everything, continuous bronchodilators, steroids. I'm assuming the ED tried everything because our colleagues are excellent and they're going to try to avoid intubation if they can. But it sounds like in this case, they did everything they can and the patient still is not responding. We have to intubate. I'm choosing an AC volume mode. I'll tell you why. This could be a little controversial and I may get in some arguments with some of my other critical care colleagues, but I'll tell you why I choose AC volume. And not PRVC here, so AC volume. If it's a severe asthmatic, they're going to have high airways resistance. So your peak inspiratory pressure may be very, very high here because of all the airways resistance it's going to take to drive in a breath. So if I choose pressure control, I'd have to set the pressure control really high to overcome that airways resistance. And if I don't choose enough pressure on them, it may not be enough pressure to overcome the airway resistance. And actually, the volume may be too low. In fact, I've had cases where they chose PRVC or other pressure mode, and the pressure just wasn't high enough, and the tidal volumes were way too low. So if I choose AC volume or a volume control, I know I'm going to target a tidal volume. Here, if there's no significant lung pathology, I'm going to go maybe on the higher side, somewhere between 8 mLs per kilo. I'm not going to ignore the peak inspiratory pressure, but if it's high, I'm almost expecting a high. I've seen high peak inspiratory pressure on kids and adults, somewhere along the lines of 80 centimeters of water pressure, 100 centimeters of water pressure. I know that's going to blow the minds of some of our therapists, but the thing that I'm going to look at is at some point after we intubate them, do a pause pressure, get a plateau pressure, make sure that plateau pressure is low. So we're not dealing with a lung compliance issue. I know we're dealing with airways resistance. And I try to reassure the therapist that peak inspiratory pressure is high because they have airways resistance. The bronchodilators, the steroids will improve that over time. So let's just put them on a volume control. It's hard to ignore a high peak inspiratory pressure, so you may have to tune your alarms to be higher here. But let's periodically check the plateau pressure, make sure it's still low so we're not causing lung injury to the alveoli. Once we got past that, I've reassured everybody in the room that I'm not crazy, that AC volume mode is the right way, even though your peak inspiratory pressures are high and it's blown their minds that we're allowing this. I got the bronchodilators, I got the steroids going in, I'm checking a plateau pressure and it's low, then I'm going to give the patient time. That peak inspiratory pressure will come down as the airways resistance improves. And again, they're still going to get the targeted tidal volume that I want. So that's why I choose AC volume. Again, you can choose pressure, but you're really going to have to titrate that pressure, and they may get too low a volume because so much of that pressure is going to be used up to overcome the airways resistance. So now part two. Okay, here's where people get nervous. So what do you do, Mike, when you see a high PCO2 level? What are you taught?
So you're taught in med school, and a lot of times even as a medical student, ventilation. You want to increase ventilation. So a lot of times we're taught increase respiratory rate. That's the gold standard usually. But I think you have something ready to discuss.
Yeah, and this is the common mistake. And I've seen some patients have some really bad outcomes because, again, you see the CO2 level. And in last episode, or 2 episodes ago, we talked about the 2 things that control CO2 level are your respiratory rate and tidal volume. And we said you don't want to change your tidal volume too much, so you go up on your respiratory rate. In this case, though, if they have asthma or COPD, it's going to take them a very long time to exhale that CO2. In fact, we said it's a 1-to-3 ratio. Typically, you spend about a third of the time in inhalation and about 2/3 in exhalation. Here, that ratio may change significantly. They may be in a 1-to-6, a 1-to-8 ratio, 6 to 8 times as long to get that breath out. Instead of going up on the rate, which blows people's minds too, they want to go up on the rate, blow off the CO2. Here, we got to choose probably a lower respiratory rate and give that patient time to exhale. That's what's going to help our CO2 be removed. Give them longer time in exhalation. So again, my eyes go to the flow curves here. What goes in must come out. If we have too high a rate and we're not allowing them to fully exhale, they're going to get something called autopeep or air trapping. And that gas that went in never comes out.
Stays in the lungs.
Yeah, it stays in there. And that is going to increase our intrathoracic pressure. If that intrathoracic pressure goes too high, it's going to reduce preload, reduce cardiac output, and we can cause our patient to have a cardiac arrest because of the high intrathoracic pressure, or it may even cause a pneumothorax and a bad outcome for our patient. So the two main things here are choosing the right mode of ventilation. It's my preference, I'm going to repeat that, it's my preference to choose AC volume control and to target 8 mLs per kilo. Ignore the peak inspiratory pressure for the time being. Make sure your plateau pressure is low. Give your steroids, bronchodilators. Choose a lower respiratory rate. Where we just talked about the patient who had metabolic acidosis, we want a high rate. Here, we want a low enough rate so that we can see that the patient is fully exhaling all of that CO2. That may seem counterintuitive, but their CO2 level will get better. If you choose too high a rate, you will potentially cause harm in your patient, especially if that exhalation limb on the flow curve doesn't get back to zero. That air is being trapped inside the lung, increasing the intrathoracic pressure. Now, probably a lower PEEP if they don't have any significant lung disease, FiO2, same as I said. So those are the exceptions, those metabolic acidosis patients and that obstructive lung disease patient, like a COPD or an asthmatic. That's how you're going to set it up, slightly different. Okay.
Sounds good. Covered a few good clinical scenarios there.
The only one we missed, though, is a refractory hypoxemia. We probably should dedicate an episode to someone with ARDS and all the ventilator modalities and non-ventilator modalities that have been used in treating these patients. But I'll just make one comment. If you have someone with refractory hypoxemia on a ventilator, there's a few things you could do, right? Again, here it's optimizing PEEP, making sure that the lung doesn't become atelectatic. You're maintaining an open lung strategy. If they have ARDS, you're going to minimize your tidal volumes somewhere between 4 to 6 mLs per kilo. You're going to look at your plateau pressure, make sure that's less than 30. But we talked about optimizing that PEEP so that we can reduce the driving pressure, which is associated with better outcomes. Now, that's only our ventilator strategies. There's a lot of non-ventilator strategies like proning. We can talk about steroids, ECMO, but for the most part, find your right PEEP. FiO2, we want to get it down as fast as we can to something less than 60%, ideally less than 50%, so we don't cause other injuries from free radical injury. So at least we wrap that up with refractory hypoxemia. There's a lot of non-vent modalities that we can talk about, but at least that wraps up some of these kind of common physiologies that, and again, you can choose any mode for someone with refractory hypoxemia. I particularly like pressure modes. I don't think I gave enough props to pressure. So here's where I like some of the pressure modes. And people are like, oh, you have to use APRV, which I have a podcast on. But here I do like pressure modes a little bit better, may keep them higher mean airway pressure, maybe more physiologic in terms of the inspiratory flow. So again, not a comprehensive look as we did in the other cases, but some comments at least. And we talked about increasing the inspiratory time. That's another advanced modality to maintain a higher mean airway pressure, which is the main thing controlling oxygenation. Just some pearls there for the refractory hypoxemia patient, but probably close it up with that. Thank you guys. And thanks again for listening to Rebel EM. We'll catch you next time.